Hi everyone, welcome to this episode of the REFERROLOGY series. Today we have Dr. Matthew Chen, and we'll be talking about dementia and cognitive impairment, which is a very important topic, and I'm sure for all of us who practice medicine, with the face of an aging population, is something that we see increasingly commonly in our day-to-day work. So maybe we can start off with a case vignette, which we can discuss around through this conversation today. So Madam Tan's a 75-year-old lady with comorbidities of hypertension, diabetes, and osteoporosis. Quite a familiar sight that we see in our general medicine wards. She presents with fever and poor oral intake, and on evaluation was found to have a urinary tract infection, for which she was started on antibiotics. So the team looking after her spoke to the family to get a bit of corroborative history to update the family. And it was found that Madam Tan actually raised some concerns that, or rather Madam Tan's daughter raised some concerns that Madam Tan was becoming weaker over the past year. They noticed that she was less active than before, like wasn't really going about like walking around so much, found that she was also needing assistance in some of her activities like showering and dressing. And the daughter is a bit concerned. She's asking whether mom has dementia and whether there are treatment options and whether she should be started on treatment for dementia if she does have dementia. So maybe framing with this case vignette, we could dive into the first question. So yeah, so when should we be suspecting dementia or cognitive impairment, Dr. Matthew?
Okay, hi. So for cognitive impairment, actually it's an umbrella term. It will include, dementia, delirium, mild cognitive impairment, and we'll go into that shortly. But those with dementia, right, they'll commonly complain of memory loss. They may be misplacing their things. They can't remember where they have left them. They have difficulty performing familiar tasks. They may have problems keeping track, of things or activities. Their appointments to see the doctor. They may have confusion with time or place, withdrawal from their work or social activities. And so these are commonly seen, in the early stages of dementia. To which there's also, possibility of having like poor or decreased judgment, changes in their mood, personality or behavior, problems with language, and having trouble with images and spatial relationships. Now, of course, when we talk about all these symptoms, it is still quite undifferentiated because there are features, that sometimes tend towards, a certain etiology, whereas some other etiologies some of these features may not be so prominent. Now, for the case vignette, right, that you have brought up, right, just coming back to this slide, how usually will you approach this, in a gen med ward then?
So I think by and large, I would firstly like to get a bit more history in terms of the domains of the patient's functions that are affected. So I mean, from this vignette, it seems that the patient is getting weaker. So I'd like to find out a bit more about whether it's just like pure physical strength kind of weakness, or whether or not there are other domains. So I mean, from the functional part, clarify the BADLs, the IADLs, and from the cognition part, apart from things like memory, also things like you mentioned, her ability to make executive decisions, her ability to do things that she was able to do in the past. And I think also importantly would be the tempo and the time frame of things. As well as at the back of my mind, I would think about the big differentials apart from like while we think dementia commonly, then delirium, especially in this context where there is infection, and also commonly in elderly patients, things like dementia. So I think broadly that would be how I would frame my approach to things.
Yeah, I think that is very reasonable. Whenever we are talking about cognition, it is very important, to also correlate with the physical function and executive function. Yeah. So you've rightly put getting a more detailed history, with regards to the basic and instrumental ADLs. think that would give a lot of information actually, especially if you correlate with the time frame with regards to the cognitive issues.
Okay, sounds like a good starting point. Yeah, so the next question that I think many gyms on the ground have, especially when we see terms in like clinic notes or like patient records, things like cognitive impairment, mild cognitive impairment, dementia. I think sometimes the juniors get a bit like confused and what do these things mean practically? So could you just take us through yeah, what are the significance of these terms?
Yeah, I think you've made a good point because I've also seen in practice where people have been labeled as mild cognitive impairment when in fact they mean mild stage of dementia. So whenever we are talking about cognitive impairment, right, like I said earlier, it is an umbrella term to cover this entire spectrum of issues. Okay, and if you look at this, I mean, it's not a very complicated graph if you break it down, but you know, all of us start off as being clinically normal, right? There is no issues, you know, with there's no memory complaints. Objectively, when you test a subject, there shouldn't be any deficits, and they should be fully functional, right? So the thing is, when people start complaining about memory issues, right? I think then the next thing to ask is then whether there is any objective findings when you are assessing them, right? Whether, you know, it's through like bedside tests or a very detailed neuropsychological assessment, yeah, whether it's affecting their function.
Okay.
So in these cases, right, if let's say if it's just pure subjective cognitive impairment, there shouldn't be any objective findings, you know, in a neuropsychological assessment, for example, and they should still be fully functional.
Okay.
Now, these preclinical years usually can last, you know, like 10, 15 years, you know, and precede, you know, the onset of MCI or dementia.
Okay.
So with progression to MCI, right, then you will see that there is impairment in the neuropsychological domains.
Okay.
But at that point in time, there shouldn't be any executive dysfunction.
Okay, so the function part is key, the preservation of the function part.
Correct. Yeah.
Okay.
Yeah, so I'm glad that you also brought up, you know, the getting a history about the basic and instrumental ADLs because it actually correlates pretty well with regards to the stages.
Okay.
Of course, those with MCI, then 10% of them year on year will progress into dementia. And that is where then you see that the function is impaired.
All right. So when we say function is impaired, once we start encroaching into IADLs being affected, that would be considered as function being impacted?
Yeah, so it really depends on what is impairing them from doing the IADL. Because if you look at IADLs, right, it can be things like shopping, right? It can be things like housekeeping. And these can be limited both by physical issues as well as cognitive issues.
Understand.
Right? If it's because of perhaps some physical impairment, right? Maybe a painful knee or someone with like a below knee amputation can't really ambulate very well, right? They can't go out and do all these things. Then certainly there's nothing wrong with the cognition in that sense. But, you know, if let's say they are forgetful and they are unable to remember the steps, you know, of having to, for example, handle a monetary transaction, plan a shopping list, that kind of thing. Then that is different already, if you see what I mean.
Understand. So this table gives us an overview, but we need to tease out the underlying reason as to why function is impaired, and that is critical. Okay, got it.
Yeah, precisely. Now, in this area of MCI, there is also a bit more delineation as to what kind of MCI this is. Because you see that those with amnestic MCI, they tend to progress to developing Alzheimer's dementia or vascular dementia. Whereas those that are non-amnestic, that means the other cognitive domains are affected, you know, things like language or behavioral issues. Then there's an increased risk of developing other types of dementias. So the subtypes here, you know, you see frontotemporal dementia, dementia of Lewy body, and Parkinson's disease dementia.
Okay, thanks.
Okay.
Sounds good. All
So
right.
then the next question is then how do we diagnose dementia lah?
Yep.
Yeah.
Yeah, so in terms of,
And
yeah, this, I think we sort of alluded to some of the mimics to exclude, but I think most of us, I think, so like you pointed out, the functional impairment part is something that's very key. But I think one of the practical things that often doctors on the ground face is that, like, can I diagnose dementia at that point in time, for example, or do I need a longitudinal kind of like time frame in order to diagnose dementia? And oftentimes, especially in the inpatient setting, because there is concomitant medical issues, so it's always like, okay, there could be an element of delirium. So yeah, so I guess these are some of the things that often come into the picture. And so how do we tease through these things?
yeah, I think that's a very good question. And the actually, if I were to pull you right to take a step back, then my question is then, I mean, what is the purpose of the diagnosis lah, of dementia? Yeah, what is the urgency here?
So
Because
yeah,
we frequently get referrals as well lah. I mean, can you come and diagnose this person with dementia, that kind of thing? Yeah.
I think
So
practically on the
what are your
ground,
thoughts on
sometimes it's about so I think a few things, right? Number one, sometimes it's about giving an answer to maybe the family. I think sometimes also there are practical issues that come into the picture. Things like, um, let's say the patient, the family has caregiver issues, and then things like nursing home comes into the picture, and then cognition and capacity comes into the picture, and then you have to fill up forms, and then the form suddenly they're saying the patient got dementia or not. And sometimes people get a bit jumpy when it comes to these things, and there seems to be a pressing urge and need to come to a diagnosis at those points. But yeah, I guess otherwise, like you challenged me to think about it. I guess in other instances, maybe formalizing a diagnosis at that point in time, or rushing it may not necessarily always be crucial. And we do have the luxury of time in terms of following up with patients. But I guess we also need to know what to follow up with and how to follow up. So I think those are some of my thoughts.
Yeah, I think you've brought up a very good point. And it's a common dilemma we face, especially if the patient requires some sort of institutionalization, right? Nursing home admission, that sort of thing. And given how the system is like in Singapore, right? There is a need to put in your application, right? Whether the patient has
exactly.
Yeah. And at that point in time, as well, is about assessing for mental capacity lah.
Correct.
So assessing mental cap, I think is a whole lecture by itself, to be honest.
Sure.
Because if at that point in time, if the patient is just recovering from delirium, then it may not be so appropriate to assess the mental cap to decide for placement at that point in time. Yeah. So even if we're looking at legally, looking at it legally from the Mental Capacity Act, then usually the decision is still to delay the assessment of the mental cap until a later date when you are certain that the patient really has no mental capacity to make that particular decision.
Understand. Okay.
Yeah. So in some cases, I think you've brought up, right? If it's very clear cut already, right? Then the history is very suggestive. It's been going on for years already. Patient is obviously debilitated cognitively, physically. You can stage the dementia and all that. Then I think that there shouldn't be any concerns with diagnosing dementia there and then.
Okay.
Yeah. And this is separate from assessing the mental capacity.
Yeah.
But there are some times where it is not so clear cut. Maybe like I said again, someone comes in with delirium. Then you do want to give it some time for things to settle down before you assess it. So most commonly, we will diagnose people with dementia in outpatient setting.
Okay.
Yeah, there's no really a real urgency per se, apart from all these like admin issues. There's no real clinical urgency to diagnose someone with dementia.
Understand.
So of course, when we talk about assessing for dementia, I think that this is quite a nice four-step approach to ask yourself when you are assessing the patient, asking yourself whether the forgetfulness or confusion is acute or chronic.
Okay.
And if it's chronic, then whether this is dementia or not. And if it's dementia, what are the complications? and what are the etiologies.
Understand.
If there's more than one.
Okay.
All right, I think that's pretty clear cut, right?
Yep. Sounds good. Thanks
Yeah.
for the
Yeah.
tip.
Now, the challenge is that when we come to diagnostic criteria, then this becomes a bit of a mixed bag, because there's quite a few organizations who are trying to standardize a set of criteria to diagnose someone with dementia. So DSM-5 by American Psychiatric Association. WHO also has ICD-10 classification criteria. And then NIA also has criteria for all-cause dementia. But I think what people are most familiar with will be DSM-4, if not DSM-5 criteria. Yeah. And as you can see in DSM-5, because there's this departure away from the word dementia, because it's quite a stigmatizing term. They actually call it a major NCD.
Okay.
Then what's a minor NCD, you think?
So one or more domains. I guess there's no interference with function. I'm not sure actually.
Exactly.
Yeah.
So minor NCD just means that it doesn't interfere with function. So
Okay.
I guess it's the equivalent of MCI if you look at it.
Okay.
All right. Yeah. So for major NCD, these are the domains they are listed, and you would see that the difference between this and DSM-4 is that you no longer require amnesia or memory to be prerequisite for diagnosis. Any of these domains that can be impaired, as long as one of them is present and there is executive dysfunction, right, can be regarded as a major NCD.
Okay.
Now, what they've also incorporated here is also neurocognitive performance, which is using some kind of objective assessment that is relevant to your population. These are like normative tests that you will do. Okay. And then, of course, you will have to exclude things like delirium or deficits that can be attributed to other mental disorders like major depressive disorder, schiz, that kind of thing.
Okay. For the neurocognitive performance tests, must it be done in all patients, or it's just something, or it's only done in selected patients?
So if you want to apply a DSM-5 criteria, right, to officially label someone using this criteria, then you will need some kind of test. So it can be something like MMSE, that kind of thing also.
Okay. Understand.
Yeah. Are you familiar with like how these domains, what these domains would include?
Learning, I'm not too sure, but I guess memory, I think I'll classify into whether there's short-term and whether there's long-term memory deficit. So forgetting things that have been done recently, like meals, like misplacing things, and longer things would be things like, let's say, things of the past and stuff, to differentiate whether it's just short-term or long-term. Language-wise, I would look at whether there's problems with expressive or receptive components of speech. So whether the patient has problems expressing himself, understanding things, if he's literate, whether he has problems with reading and writing. Executive function-wise, I'll look at things that, let's say this is someone who used to cook and stuff like that. I'll look at whether he can still go about that. I guess things like, let's say, handling money and stuff will also count under executive function. Complex attention wise, I'm not sure exactly what counts as complex attention, but maybe things that some of the executive function things may also have elements of complex attention. So I guess if you cook and stuff like that, you do need some element of complex attention to put things together. Maybe like reading, perceptual, motor, okay, I'm not very sure practically how to assess. I'm not sure whether apraxia, things like combing hair, and things like that would count as perceptual motor. And I guess social cognition wise would be things like, let's say they remain socially appropriate in terms of like speech, behavior, interacting with others. And yeah, that would be my attempt at eliciting these different domains.
Hey, that's very good. That's very good. So you are quite right, I mean, in terms of the memory, yeah, some would think about short-term, long-term memory. You can also think about it in terms of like recalling freely. So meaning that they are just recounting things on their own, or whether they need some kind of cues. Then in learning is like can be like things like implicit learning. So they can be learning new skills, for example. So for someone, with this domain that's impaired, they may not be able to keep up, with learning how to use like maybe the latest mobile phone, that kind of thing, right? The smartphone.
iPhone 12. Okay.
Wow, free advertisement.
Kidding.
Then language-wise, yeah, so you are quite right about both expressive, it can be things like word finding problems, can be fluency, grammar, syntax, and receptive language. I think in terms of the executive function, the example you brought up of cooking actually is quite good, because cooking itself probably would cover both executive function and complex attention, because executive function will cover things like planning. You need to plan getting the recipe, the ingredients. It also involve like decision making, how much to buy. You need some working memory in there as well.
Yep.
If let's say you don't have this particular ingredient, then whether you have that mental flexibility to swap out with another condiment, complex attention also will be things like sustained attention. So someone, for example, who is inattentive, getting distracted all the time, that will be a problem with complex attention. Attention itself can also be things like divided attention, selective attention, and the information processing speed.
Okay.
Perceptual motor, actually, it also, I think you're quite right about the apraxia part, also has some bit about visual perception, especially for some, they may have like hallucinations, have problems with like visual spatial, visual constructional reasoning. And then social cognition wise, yeah, you are also right about recognizing emotions, how they have insight into their own social interactions with others.
Okay.
Yeah, so of course, when we are talking about this, right, and we are wanting to rule out delirium, then this is quite a common tool, that has been used. There are others as well. This is actually from the States, from Prof. Sharon Inoue. So if you were to go through like delirium kind of literature, her name comes up quite a lot, and because she's quite a strong proponent for the CAM criteria.
I see. Okay.
Yeah, but it's actually very similar to the DSM-5 criteria actually, and you will see that it's got both high sensitivity and specificity.
Okay.
Other tools that you see people use is like 4AT, for example. Yeah, that's from the UK.
Okay.
So this is pretty clear cut, right?
Yeah.
Okay, yeah, and especially when we are thinking about delirium, of course, we need to think about what are the underlying precipitants and predisposing factors, and all these will need to be addressed. Yep. So a mnemonic, to think about would be the delirium's mnemonic.
Okay.
Okay.
That's good. Yeah. Thank you.
Then as we talk about dementia, then we also have to think about potentially reversible causes, right? Before we properly label dementia. And this is, I guess, kind of provides the segue, in talking about how do we then perform investigations, to rule out all these reversible causes. And you will see that quite a number of them can be done by blood tests, and some of it will need some form of neuroimaging. Okay.
Sounds good. Okay. So yeah, so exactly the next question. to find out a bit more about the assessment components of a cognitive impairment and working towards a diagnosis of dementia. So I guess like we also want to talk about like what blood tests do we do, what kind of brain imaging is indicated, then the different tools that we have. I think commonly we see MoCA and MMSE, so wanting to know a bit about the differences between both. And I also understand that there's a role for neuropsychological assessment. I'm not very sure what exactly that entails and who it should be done for. So maybe we could have a talk about these things.
Okay, right. So for MMSE, there's so many versions actually.
Okay.
I mean, now that we are in this period of time where we are kind of transitioning to the next generation EMR for Singapore, right?
Yeah.
There's also, been a lot of discussion about which version of the mini mental state to use.
Okay.
Yeah, there's actually quite a few
Oh,
going
I didn't
around.
really know. I just always Google. And then,
sorry?
I didn't know that there were various versions. I normally just Google and then use whatever turns up before me.
Correct. There's quite a lot, and there's quite a lot of history behind it.
Okay.
So the original one, the OG one, was by Faustin and Faustin.
Okay.
And this was, I think, published in like 1975. I think it was a husband and wife team.
Okay.
Yeah.
Cool.
And I think with time, right? Actually, there's different versions that came out. There's like the standardized MSE. There's in Singapore, there's, I think amongst the different institutions, there's also quite a few. And this is the one that was, I think, if I'm not wrong, is from Tan Tock Seng.
Okay.
And so this is the one that's validated in the local population. And you would see that like all other MMSEs, there is a need to know what the educational level is. Yeah, because the cutoffs are different and even depending on the age as well. Okay, so in these cases, right, for example, for our lady, if let's say she's 75 years old, right? So if let's say she has had less than 6 years of education, the cutoff for her, there's a normal CMMSE score will be 18 and below. Yeah. Whereas if she had 6 years or more of formal education, then the cutoff actually is increased right to 22.
Yep.
Okay. And then for MoCA, MoCA itself is also validated in Singapore. There were actually a couple of versions too.
Okay.
Yeah. And this is the one I think that most of us are familiar with, and it's once again also adjusted for the number of years of education you have.
Okay.
So as you would imagine, as part of the history, right, it's also very important to ask about things like your level of education as well as your occupational history, because that then adds on to the information we have to make an assessment based on all these like neuropsychometric tests.
Okay.
Now, to your question about what's the difference, now I think broadly, if you look at it, MMSE and MoCA actually covers some areas, some domains that are the same, whereas there are some domains that are exclusive of one another.
Okay.
So, for example, like things like comprehension, MMSE then would have the 3-step command, right? Getting the paper, folding in half, blah, blah, blah. Whereas MoCA, such a domain is not tested.
Okay.
Yeah. Whereas, like for example, MMSE, like vigilance is not tested, whereas it's tested in the MoCA. So I think one has to also bear in mind the differences in the domains that are tested.
Sure.
But what this means is actually in terms of the pitfalls actually, because the ceiling effect for MMSE actually is more evident, especially in more educated patients. Okay. So you may not be able to distinguish those, with MCI, early dementia. But I think from moderate dementia onwards, shouldn't be too bad in terms of performance. Whereas MoCA is not too bad. It probably performs better than MMSE when you're looking out for like earlier forms of cognitive impairment or dementia.
Okay. So the
Yeah.
MOCA in a sense is a more challenging test to do than than the MMSE lah.
Yeah, and it takes a bit
Okay.
longer.
Okay.
In that sense, right? Because if you see coming back to the MOCA, there's having to do like a very simple kind of trails test, right? To see your visual spatial, you need to draw a cube, and also there's a clock drawing test. Whereas MMSE, I think in terms of the drawing, really is just the intersecting pentagons, lah.
Yeah.
Okay.
Sounds good.
Yeah. And the thing is that both tests you need to pay in some form.
Okay.
If for MSE, I think from 2000 onwards, you need to pay for the manual and the test forms.
Oh, okay. I never knew.
Never knew, right? Yeah. So actually, the company that has helped them manage this is, I think it's called PAR, and they actually have been hunting down people who are not paying properly.
Okay.
But in the research area, if you are going into that.
Okay.
Yeah, so make sure that you are using the right version. Yeah, so CMMSE itself, we are certain that you don't need to pay.
Okay.
Yeah,
Okay.
because it developed from another variation of the MMSE.
Wow. Okay.
Yeah, there's a whole history to this.
Sounds complex.
And MOCA from last year onwards, you need to start to pay a training fee, and then you need to recertify every 2 years. But the test itself is free.
Wow. Okay. Interesting. Okay.
Yeah. So I think in terms of systems-wise, when you're running things, all these things be taken into consideration.
Okay. So wait, practically speaking, if I need to do an MMSE myself, then I should use the CMMSE that you mentioned, that one free, right? Is it?
Yeah, or if let's say if it's a test that's already present in the institution probably would have paid for it already.
Oh, okay. So I can use whatever is validated in my as in like whatever my institution uses without having to worry. Okay,
Yeah.
Understand. Okay.
Yeah, they should be keeping track on the back end.
Okay. Can.
All right. Of course, sometimes these tests, right, may not yield that good amount of information, even after you've taken a history and all that.
Okay.
And so this is where we consider things like a neuropsychological assessment, which can yield more information.
Okay.
Yeah, so like I mentioned, it's usually based on applying, some kind of battery of assessments to test different domains. Okay, more intensive lah. The whole thing usually takes about 2 to 3 hours.
Okay, and who does these tests?
So these are administered by a psychologist, a neuropsychologist.
Okay. And when do we need to get people to do these tests?
Okay, so there are some practical users, especially if let's say for someone with traumatic brain injury, right, that now has a cognitive impairment, and you want to tease out a bit further. Sometimes it may not be so clear cut, and so by knowing the types of domains that are affected can give you a better idea of what are the underlying etiologies lah. Because later on you will also find that the treatment for the different types of dementias can also potentially vary lah.
Okay.
You can also use it to help in terms of like the measurement of recovery, measurement of treatment response, so to speak. Okay.
Yep.
Now, I think you mentioned earlier, not so familiar, right? Being with the different domains. And so usually they test for things like memory, attention, processing speed, reasoning, judgment, problem solving, spatial and language functions. And how it is like, usually when you get the report, right, of course, they will be assessing what the reason for the referral is in the first place. And of course, getting a corroborative history on their own, also understanding the background history, getting the social history, highest educational level, occupational history, medical history, functional history. And together with these subjective information, right, that's also objective test that's done, and it's normative, meaning that it's based, on the local population norms.
Okay.
Yeah, so they'll be doing things like modified Bartel's index, Lawton's. There's also a Boston naming test that you can use to assess for language. Trail tests can also help, with things like executive function. Now, R-bands is the repeatable battery for assessment of neuropsychological status. And it's this entire battery of tests. They do like things like telling you a story. You have to remember different parts of the story.
Wow, okay.
Testing recall, picture naming, to test your semantic fluency, your digit span, how you quote, how you recall.
Okay.
Yeah, so it's very extensive, and it's also something you have to pay for.
Okay.
Also, of course, you want to test the emotive state, right? So you do like a geriatric depression scale, for example.
Yeah.
In certain cases, right, where they've got behavioral issues, behavioral disturbances. Okay, this is some of the complications of dementia, if you will. Right. There's also a neuropsychiatric inventory that they do to see the level of behavioral disturbance. So as they are doing all this, right, they are also performing a mental state exam, how the patient is in terms of their test-taking behavior as well.
Yeah.
How cooperative are they with the tests, the speed at which they are processing, and gauge it against what they perceive to be the intellectual ability of this person.
Okay.
Yeah, so if someone who is like high functioning, like CEO, that kind of thing, so they should naturally be quite fast in certain domains, or even faster than the baseline norms.
Okay.
So ultimately, you have to take all these subjective and objective information and be able to interpret the results. They'll tell you which are the domains that are affected, ultimately come to a conclusion, what they think the diagnosis is and what they recommend. So recommendations that we see sometimes would be, need some psychoeducation about dementia, perhaps a daycare placement because there's quite a lot of caregiver burden, that sort of thing.
Okay.
You would imagine this entire thing sounds very useful, right? Everyone should get one, right? But of course, we have to balance this with the resources. This is quite resource intensive.
Yeah,
and
it is.
Usually, we send those who are higher functioning, may not be so clear-cut sometimes for this kind of test. Yeah, because it can also compensate pretty well.
Understand.
Yeah.
Okay.
Yeah. Whereas like those that are very clear-cut already, you don't really need to go through this and make them spend, a few $100 just to arrive at the same conclusion. Yeah, then you can save that money.
Understand.
So there's some cost concerns here as well.
Yeah. Thanks. That's really insightful.
Yeah. Okay, no worries.
Okay.
So of course, coming down to the your question, right, about what kind of investigations to do. I also bring you back to what are the reversible causes here. And just by looking at it, right, you know that some things you have to assess the mental state, right, whether there's any underlying depression, psychotic, late onset skids, that kind of thing. But otherwise, the rest, would be doing simple blood tests, and these are actually all listed out, in clinical practice guidelines by MOH.
Okay.
Yeah, there is one, and it's actually quite a while back, but still relevant till today,
Okay.
Yeah. So when we rule out metabolic causes, just by doing a panel of like full blood count, urine electrolytes, doing the serum calcium, glucose, LFT, TFT, B12 folate, that should be enough.
Okay.
In fact, some may not even be routinely done, but this is the usual panel that we do.
Okay.
Okay. Now, the things that are definitely not routinely done would be things like routine neurosyphilis testing. Because even with the test that we have, it's also hard to interpret.
I see.
So only if the person displays clinical features of neurosyphilis, or if it's young onset dementia, or if like there's a history of STI, then that is where you consider testing.
Okay.
Other things like biomarkers, it's still pretty much in the research field. There are some cases where you would do it in the clinical sense, but it's also not done routinely. Things like CSF tau or CSF like beta amyloid, that kind of thing, also not done routinely.
Okay. Yeah, that's clear.
The other thing is neuroimaging, and this is quite a contentious area. There is no consensus. But you can consider things like a structural imaging, CT or MRI, or functional imaging. So this will be doing like a PET scan or a SPECT. In this area, right, one would say that actually dementia itself is a clinical diagnosis, right? But it is helpful to get some kind of neuroimaging. From what we found in practice, there are some times where we have picked up other pathologies that can explain the person's cognitive impairment. Of course, in these cases that you see here on the screen, these are more typical of Alzheimer's pathology, where you see in image A, there is some hippocampal atrophy. Okay, both sides. And in fact, there is a scoring system for this.
Okay.
Called the MTA scoring, the medial temporal lobe atrophy score.
Okay.
And then for image B, you see that there's also some temporal lobe atrophy on the left side. Actually, both sides also have. But that's what the arrow is pointing to. C and D actually are more of a vascular pathology. So C, right, is where you see on the MRI, you will see clearly about the white matter disease burden. Right? These are all like periventricular, like hyperintensities on a T2. Whereas for sorry, not, I think that's T1. Then for D is will be a T2 GRE and then you see that it's pointing to a microbleed. So let's say it's in a particular distribution, then one might even think about other pathologies. If there's a lot of all these like microhemorrhages, we're thinking about other things like cerebral amyloid and angiopathy. So the treatment-wise then will be quite different of all these, which we will discuss in a bit. Then you also have PET scans. This is like a FDG PET. So in a way, these are still pretty much in the research space, but they have already been quite promising, in being able to differentiate between different etiologies of dementia, or some can even tell you whether there is going to be predict the risk of dementia or not.
Understand.
So then to think about this, right, there is some consensus from the Canadians where they think that, if it's something of younger onset dementia or something that is very unusual, atypical, of the typical trajectory, then this is where they advise to proceed with a scan. So you see here, if for someone aged 60 and below, if it's a rapid progression, if there's a recent head trauma, there's unexplained neurological symptoms, maybe there's a background history of cancer or like concomitant use of anticoagulants, right? If you suspect that there's MPH when you're taking the history, right? Then that is one thing to consider actually. And then if there's any other new localizing signs, in terms of the neurological examination or gait disturbances.
So this is a more like rationalized approach if you really want to rationalize each scan that you do. But at the same time also, sometimes it is still fair to get a baseline neuroimaging to look for supportive clues as well as to exclude other causes of cognitive impairment or dementia that may be picked up on scans.
Yeah, definitely. Our practice is kind of shaped by our experience. And I mean, we had in the past, where someone who appears to be well with some cognitive impairment, but no neurological deficits, right? Ends up having to have some kind of pathology there, and so I think really depends on the amount of resources you have. If it is not a concern, then I think it's still reasonable to perform a scan to make sure you're not missing anything.
Got it. Hey, thank you.
No worries.
So maybe shifting gears a bit, so we've talked about the evaluation of dementia. Next, I guess once dementia is diagnosed, how do we grade the severity of dementia? Maybe you could also share about the implications of the different stages or different levels of severity of dementia.
Yeah, so I think this is once again a very good question, and sometimes not quite well understood by some of the junior doctors. And the key phrase here, the key word here is function, and you will see that this actually would echo, throughout the different types of models that I have prepared for you. So I think that the easiest one to use it actually goes back to the DSM-5 criteria. So if there's impairment with the IADLs, then it's mild. If it's impairment with BADLs, then we moderate. And then if you are fully dependent, then it's severe.
Okay. Yeah.
I think that's pretty clear cut to think about. And what this entails, right, by staging the dementia, I think has a few implications. One is that, for example, for someone with mild dementia, if they were to come in with kind of functional decline, apathetic, not talking, then it makes you wonder whether there's some other pathology going on, right? So this will help in terms of your ability to diagnose.
Yeah.
Okay, so it's important to be very clear about the entire time course of things. We recently had one lady with mild dementia, and I think the initial impression when she came in for functional decline, was that the dementia has progressed. But if you go and think back to the history, then it becomes apparent that there's some other pathology going on. And true enough, when she went for a scan, it did show that there was a CNS tumor in the spine.
Okay.
Yeah, so it is therefore very important to be very clear, about the entire trajectory of things. Yeah, so if, for example, someone with like Alzheimer's pathology, right, we know that it's a very slow, insidious, kind of gradual, progressive memory loss over the years. So for someone like with mild Alzheimer's all the way to severe, it usually takes about 8 to 10 years.
Okay.
Yeah, so any changes in between, and they suddenly have a functional decline, then you really have to seriously wonder whether there's something else going on, rather than blaming that the dementia has progressed from mild to severe just like that.
Understand.
Which is very unlikely. The other thing is, of course, I think prognostication. Okay, and by being able to counsel, the patient and family with regards to how things will go, so that they can also mentally prepare themselves of what's going to be coming up on the road ahead.
Okay.
And actually put in, all the interventions, at the appropriate timings.
Okay.
So things will be like, if let's say, you know that they require assistance with like basic ADLs already, then of course, there definitely will be some caregiver stress. You may need to then also put in some financial aid as well, right? You need to make sure that all the grants are, in that kind of thing.
Okay.
Right. Yeah, and then in severe stages, you need to also then prepare for like things like home equipment, that kind of thing. Right.
Okay.
So by knowing the stages can also help you prepare for the road ahead.
Yep.
And of course, at the very early start, once they have been diagnosed already, at some point in time, you should also start talking about goals of care, because you already know that this is going to be terminal, right? So they need to know where they're heading, and in the event that they are still able to express, their goals and preferences, then certainly you should pursue things like an ACP.
Yep.
The other thing is for some, with mild stages, also knowing about their financial situation. Sometimes, they are still managing money, that sort of thing. So it's also good to get things like a lasting power of attorney in place early, because by the time they lose their capacity, and then you want to involve, the legal fees or that of getting a court-appointed deputy, it can sometimes be quite stressful for the family if they want to utilize funds, in a very short span of time.
Understand.
Yeah, okay. So there is a lot of implications here. Yeah, and I mean, coming back to the urgency of diagnosing dementia, I think it also comes down to understanding the implications of even labeling someone with dementia in the first place, because there's all these downstream effects to consider.
Yeah, understand.
Yeah. Another staging system that you will see, right, quite commonly is the clinical dementia rating, CDR, and that's actually quite a nice way of classifying dementia in terms of the score, right? If
Okay.
it's 0, you know that there's no cognitive impairment at all. 0.5 is where, you know, probably questionable, maybe MCI kind of region. Whereas mild, moderate, and severe will be 1, 2, and 3 respectively.
Okay.
Yeah, and they assess these 6 different domains, right? And on top of that, the beauty of this scale, right, is that if you see someone, for example, with typical Alzheimer's dementia, right? If let's say he or she is in the mild stage, right?
Yeah.
There should be concordance amongst all these domains in terms of memory orientation and all that.
Okay.
So if let's say you perform a CDR and you find that actually, you know, some areas are impaired, some are questionable, some are severely impaired kind of thing, right? Then you need to wonder whether there's some other pathology going on.
Okay.
Yeah.
So this scale was sort of like carved out based on the Alzheimer's archetype kind of framework,
Yes.
is it? Okay, understand.
Yeah. So in memory clinics, a lot of them will be using a CDR rating.
Okay.
Yeah. You also see this being used sometimes, the fast staging.
Yeah.
So then this classifies the stage of dementia from 1 to 7, and from 6 and 7, right? There's even subdivisions lah.
Okay.
And this itself gives quite a good idea of where they are at in terms of their disease. In a way, you can use it to prognosticate as well.
Okay.
And the other thing about this, right, is that they should be most of the time moving from one stage to the other.
Okay.
So if let's say from 6A you suddenly become 7A, and then you skip 6B all the way through E, then you need to wonder something else has happened also lah.
Okay.
So these while are staging tools, right, they can also be very practical diagnostic tools.
Understand.
Yeah, and this is just like a kind of like an overview of what we discussed.
Okay.
Although I'd like to point out that the CDR staging, right, 0.5 will be under MCI lah. Mild AD will be 1.
Okay, understand.
Yeah, I think there's some issue with the diagram, but yeah, the rest should be pretty correct.
Okay.
Yeah, GDS here is not a geriatric depression scale, but rather the global deterioration scale. It's one of those other staging systems, but I think I mean with all these staging systems, there's no need to know so much about it unless you know you're doing a lot of cognition work.
Okay. Thank you.
Yeah, and this once again gives you a idea of how it correlates, you know, with the MMSE as well as the overall trajectory lah.
Okay, got it. Thanks. Okay. Yeah, maybe next we can talk about the different causes of dementia. So you've talked about reversible causes, and then in terms of the other big groups, apart from Alzheimer's, I think there's also vascular Lewy body dementia as well as FTD that you've talked about. So maybe you could just take us through some of the key defining features of each of the different dementias. So I guess sometimes yeah, I guess sometimes we just assume everything is Alzheimer's, and sometimes we don't make the effort to properly characterize. So maybe it would be helpful to point out what are the key salient things to look out for.
Yeah, thanks. So I think that's a very good question, and I think before you even embark on history taking, it's important to equip yourself with the knowledge of what the different features are. Because we see a lot of people always talk about just short-term memory loss, but they would then also forget about the other features or not really asking about it. Now, itself, dementia is an umbrella term. Of course, like you said, there is different subtypes. Alzheimer's is the most common one in 60 to 80%. But the thing is that actually, I mean, when they were doing like neuropathological testing, right? Those with like just pure Alzheimer's end up to be like less than 10%.
Okay.
With a majority of them, right, to have mixed dementia.
All right.
Yeah, so maybe like Alzheimer's together with vascular dementia, for example.
Okay.
Okay, and especially in our local population where, you know, comorbidities like hypertension, hyperlipidemia, all these cardiovascular risk factors, diabetes, then I think the vascular burden is also pretty high.
Yep, indeed.
Yeah. Now, if we were to talk about Alzheimer's disease, I think just to bring you back to medical school days, is really the deposition, right, of all these like tau protein, amyloid plaques, that kind of thing. And it takes quite a long time for all these things to build up and cause neurotoxicity.
Okay.
So, which is why then you see that the way Alzheimer's presents, it's very gradual, very insidious. And in fact, sometimes when we are questioning them about the duration of short-term memory loss, you may not get such a clear answer.
Okay.
And in fact, sometimes you may get more clues as to executive function because of memory issues from the assessment of the instrumental ADLs.
Okay.
So by asking more about the IDLs, it's important to be inquisitive, right? If you tell me like, oh, they stopped cooking like 2 years ago, but the short-term memory loss is only 1 year. Can you tell me more about this cooking incident? Like what brought about the stoppage of cooking at home? Thing. Yeah, maybe there was like some issues with fire safety, for example, right? Then they continue to drop their memory and actually the short-term memory loss is longer than that what was said previously.
Okay.
And you can divide the deficits into both amnestic and non-amnestic. So amnestic ones are more commonly asked, like in terms of the recall, the learning, whereas the non-amnestic ones would be things like executive dysfunction and all that. Okay. And like I said earlier, the prognosis is really 8 to 10 years, by which you will see quite severe cerebral atrophy, particularly as you can see in this diagram on the right. There is quite severe hippocampus atrophy. This would usually tend to be global as well. So if you see things like asymmetrical hippocampal atrophy, then you also have to think about whether there's some other pathologies.
Okay.
So that can be things like frontotemporal dementia, for example.
Got it. Okay.
Yeah, when you see the CT brain. Now, vascular dementia is now, I think, getting quite a lot of spotlight in terms of the research field. Not that AD doesn't, but in vascular dementia, because I think right now there's growing evidence, that the prevention of dementia, can be by controlling things like diabetes, and then controlling tension because of the SPRINT trial. And SPRINT trial was then also extended to the SPRINT MIND trial, and they find that by controlling the blood pressure, you can really reduce the risk of developing dementia.
Okay.
Now the thing is that the features really depend on how badly are the vessel damaged and what are the areas of the brain affected. So if let's say you're talking about like a big stroke, right? You may see a cortical stroke. You might see a very obvious stepwise decline, which people tend to ask about in a history. But we also do see some with those kind of chronic microvascular changes, and that accumulates over time, right? So you may not see that stepwise decline so obviously.
Okay.
Yeah. And while the DSM-5 criteria has its own criteria for vascular dementia, I'd like to also bring your attention that there's actually other criteria available out there, and this is NINS Aaron. So this one, right, you need all these 3 criteria to be present. So dementia, you need obvious stroke, okay, stroke disease, and then there must be a relationship between the two.
Understand.
Okay. Yeah, and as you've rounded with us before, right? We also talk about strategically placed infarcts. So this, as you can see in the second point, right, this will be areas of the angular gyrus, the thalamus, basal forebrain, or PCA and ACA territories.
Okay.
Yeah, so knowing the territories will also be important in terms of the diagnosis. Because sometimes when we do go down to the nitty-gritty, sometimes you may just really be getting pure AD with like concomitant cerebrovascular disease, but not necessarily vascular dementia.
Okay.
Right.
Yeah.
Yeah, and clinical features wise, there most of the time will be a neurological deficit lah.
Okay.
Okay. Now, if let's say there is no neurological deficit, then you probably can just label it as possible vascular dementia rather than probable.
Okay.
Yeah. For all sorts of dementia, if you want a definite diagnosis, right? What do you think that is?
Definite.
Definite.
Biopsy.
Biopsy law, correct. You need neuropathology. So I think for most living people, you end up having a probable, possible diagnosis. Okay. Now for vascular dementia also, I think some of the key features, I mean, although this is all written in literature, right? What we find is that there tends to be, what is more pervasive here is like the emotional aspects.
Okay.
Yeah, so those, with like emotional incontinence lah, mood lability lah, that kind of thing. And then together with strokes in the brain, we are more inclined to think that there's a vascular component to this lah.
Okay, so does this tend to occur in patients with more like frontal kind of vascular infarcts, or even just generally when there is vascular dementia that tends to, because I always associated like emotional lability with a frontal kind of release or disinhibition element of things lah.
I think it can happen either way.
Okay.
But more seen in frontal lah.
Okay.
Yeah. And then what is also more obvious in terms of like vascular dementia is that there is executive dysfunction that is quite obvious.
Okay.
Sometimes the memory, the short-term memory, all that actually is not too bad one.
All right.
If they just just stroke out one particular area, the memory is not so bad, but they have a problem with executive function.
Got it. Okay.
Yeah, so these are the final points lah. Yeah, on top of what you read on the internet.
Yeah.
Dementia of Lewy body wise also sometimes takes a while to diagnose. Now this sometimes you don't necessarily see memory issues as well, just like vascular dementia, but it becomes more prominent as it progresses lah.
Okay.
But what you see early, right, will be things like attention deficits. So they tend to be easily distracted, and sometimes they also get mislabeled as delirium. Yeah, because they are very inattentive and all that, and sometimes we see in the earlier phases, right? They just keep getting admitted for delirium rather than a proper diagnosis of DLB lah.
Okay.
So it takes some time to tease out that part as well. But what is in the diagnostic criteria, according to the fourth consensus report, right, is that you actually need to look out for these core clinical features lah. So fluctuating cognition, like I mentioned, they get these like very well-formed, detailed visual hallucinations as well. Yeah, so by that means that they can describe to you very clearly. And what we hear very often, right, is like they see things like insects, or like they keep seeing like the sand on the bed, that kind of thing.
Okay.
It can be very well formed, like maybe you can see entire funeral procession, that kind of thing. So these are very clear lah, as compared to some who just see light, some see some shadows, not very well formed. Okay, in contrast lah. Then they sometimes also may complain of REM sleep behavior disorder, which may even precede the cognitive decline.
Okay.
So they'll be like thrashing about in bed, can't sleep well, kind of thing. And then usually it's the spouse who will report that to you lah. Yeah. And lastly is Parkinsonism. So you may or may not get Parkinsonism all the time. Okay. So by just having two or more of these core clinical features, you can say that it's probably DLB already. Now, there are some biomarkers as well, like SPECT, PET, polysomnograph, or the iodine myocardial scans lah. So in these cases, a bit plus minus. Actually having all these clinical features should be good enough.
Okay.
All right.
Yep.
There are some other supportive clinical features, but as you can see, it's not part of the diagnostic criteria anyway.
Okay.
But what we find is that, invariably sometimes, there's those that are admitted for delirium, right, are given some kind of antipsychotic medication for sedation purposes, and they end up being very sensitive. The behavior gets worse. Then this will also make you wonder whether this is DLB rather than delirium.
Okay. Yeah.
Now, with DLB, right, because you see that there's Parkinsonism involved as well. Sometimes it's spoken in the same breath as Parkinson's disease, dementia.
Yeah.
So of course you need the diagnosis of Parkinson's disease, right? But there is a 1-year rule that applies here. So meaning that for someone with DLB, they should be having all these Parkinsonism features, right, for less than a year. Whereas for PDD, 1 year or more.
Okay.
So that kind of differentiates between the two.
Okay.
Yeah, you tend to see PDD more in the later stages of Parkinson's disease anyway. So they would have had it for years already, and it's really towards the end where they have developed signs of dementia.
All right. Okay.
Yeah. Now, FTD is then a bit of an oddball because it tends to affect the younger ones. So the middle age group, and there's actually different subtypes. Have you seen any FTD before?
Not in recent times. Not really that I can recall, actually.
Okay, because I must say, if you see one, particularly those like the behavioral variants, it's hard to forget because they can have quite severe behavioral disinhibition. So quite in your face, can be challenging your authority, very inappropriate behavior.
Okay.
Okay. Yeah. So as you can see, this is like a diagnostic criteria. And apart from the behavioral variant FTD, there's also the ones that are more related to language. Primary progressive aphasia is the other differential or subtype.
Okay. Yeah.
Okay. Now, the survival time from the symptom onset usually is like 6 to 11 years.
Okay.
Yeah, but from the time of diagnosis usually is less than that. So they decline much quicker, than you will see as compared to Alzheimer's dementia, for example.
Okay. Okay.
Okay.
Thanks for that overview of the different types of dementias. So I think now maybe we could talk a bit about the management of dementia. I think wanted to ask a little bit about the pharmacological treatment. I think firstly because oftentimes we are not very sure when it started and even like which domains it actually tends to benefit patients in. And I guess also I do understand that, however, pharmacological treatment is only one of the aspects of the overall management of dementia. But yeah, so maybe you could just take us through what's important in the management of dementia overall, and maybe just dive in a bit into the pharmacological aspect of things.
Thanks. I see that this is probably one where there's the most number of questions, based on the slide.
Indeed. Yeah, I guess it's one of those things where oftentimes we may see patients who, let's say, are on treatment, then sometimes they are like lost to follow up. They're not sure whether the treatment will still benefit the patient, whether you should take it off, continue it, whether sometimes when memantine is added on, should the other agent stop or continue. So I guess these are some of the things that we face on the ground.
Okay. Yeah, I think that's a very good point. And as you rightly mentioned, the pharmacological management is just the tip of the iceberg. Because the overall management of someone with dementia has to be multimodal and individualized, and it comprises a lot of non-pharm interventions. There is a focus on person-centered care, and this can only be achieved by having the clinical team on board. You also need the caregiver to be well educated about the overall trajectory, how you counsel them, right? The overall trajectory, of the dementia, what to expect. And because of that, sometimes, they may be especially stressed, because of BPSD, they may be having to deal with the person being agitated, having hallucinations, that kind of neuropsychiatric manifestations. So at that point in time, caregiver burden also very important to assess. And for someone with dementia, also need to assess for the risk. Yeah, whether they are at risk of malnutrition because they live alone or they are alone in the daytime. They're not taking whether they are taking their medication or not. Whether they still continue to cook, despite forgetting to off the stove, for the uptime time. Some of them still prefer to drive. I have some patients with dementia who are still driving. They are still able to make the proper judgment, and if they are driving on a familiar route, they can still manage it. So they are still allowed to do that after a formal driving assessment. Yeah, and of course need to think about whether they are vulnerable to abuse. So we've seen in very landmark cases in the past where someone with dementia had been abused financially and dished out, more than $1 million in assets, to the donee who was not even a family member. Yeah, and this was because there was an LPA.
I see.
So these kind of things, we need to be quite thorough in our assessment and counseling. There's also other non-pharm interventions that perhaps are even as good, as pharmacological treatments. So things like cognitive stimulation therapy, that is one example based on the psychological treatments for dementia. But to address your question of pharmacological treatment, for the drugs that we're going to talk about, they have been approved for Alzheimer's, dementia with Lewy body, and PDD. Yeah, vascular dementia is a bit of a gray area. That there is kind of mixed evidence with regards to that. But for these drugs that we're going to talk about, they target the biochemical abnormalities. So they don't really modify the underlying neuropathology or its progression. That's being looked at in terms of the current research field. But I think even of late, those trials, of all these biologics, like aducanumab, that kind of thing, has not been very fruitful, unfortunately. But when we are talking about treatment considerations, there's quite a lot of things we need to think about. We think about what is the underlying etiology, because as you can see from the indications, for example, someone with FTD may not be able to respond to this treatment that you are giving them. What stage they are in as well, because that will also affect the type of treatment that you decide to give. The clinical profile, the comorbidities of the patient, are you already prescribing quite a lot to the patient, and is it really worthwhile to add one more pill for this particular aspect? Because the next thing is then, what are you expecting to see in terms of the benefit? What are the side effects that you need to weigh against, and how much it costs, which I guess with more and more drugs coming into the generic forms, this is becoming less and less of a concern. Now, of course, if you were to treat earlier, then of course you will see that there is better effect. By the subsequent examples of the medications you see, if you treat earlier, then I think you will probably see a better outcome as compared to starting it in a severe stage, for example.
Understand.
So in terms of the cholinesterase inhibitors, which is one of the two classes that we're going to talk about, is one of the longer kind of experience that everyone has had. And of the three different ones, right, we've got donepezil, rivastigmine, and galantamine. Are you familiar with these drugs?
I not super. I mean, I've seen patients who are on it, kind of know a bit about like the side effects. But in terms of how we choose amongst them, I really don't know. So I am not the most familiar with them.
Okay, can. So I mean, we actually don't carry galantamine in our pharmacies. Yeah, so you will see donepezil and rivastigmine more. Yeah, now you will see for AD, people tend to give donepezil or rivastigmine. Whereas for those, with like DLB or PDD, because of all these like movement disorders, there is a slight benefit in terms of giving ribostigmine.
Okay, I see.
Yeah, but as you can see, right across the board, there is really just a modest benefit in the cognition. MMSE difference, the mean difference is 1.37, before starting and after starting.
Okay,
Based on the trials that has been done.
I see.
Yeah, so I mean, if you were to think about like someone in like a severe stage of dementia, right? Let's say MMSE of like 0, by adding on like 1 or 2 points, it's hard to see that translate into the obvious change in ADLs.
Okay, understand.
Yeah, which is why it's important to know what stage they're at.
Okay.
Okay. But based on the studies that have been done so far, these drugs also have benefits in terms of the global change that's observed by the caregiver and the physician, and the activities of daily living.
Okay.
Yeah, so you said that you are quite familiar, right, with the side effects, and actually really, if you look up the internet, wow, there's like a whole list, right?
Yeah.
But the more common ones you see are the GI side effects.
Okay.
Yeah, for donepezil, some very small number reported vivid dreams, some leg cramps. Yeah, and if let's say that there is really an acute worsening of the cognition or agitation, then you will need to stop the medication. But otherwise, you can just keep it going. You see.
Okay.
Of course, there are some where we really stop is because there's like bradycardia, or the symptoms get too bad, even after holding out for 1 to 2 weeks, lah.
Okay.
But most of the time, all these side effects should wear off once the body gets used to the drug.
Okay.
Yeah.
So you mentioned that you can normally continue it. So let's say patients, as they progress and they reach a stage of advanced dementia, in those instances, would you normally hold it off, or if there's no need to rock the boat, normally it's still okay to keep it on?
So that's a very good question, and this was actually answered by this trial called the Domino trial.
Okay.
So there was a double-blind discontinuation study that was done, and they found that by stopping donepezil, right, in patients with moderate to severe AD, there's actually quite a significant cognitive and functional decline.
Okay.
You get
Okay.
more neuropsychiatric symptoms, and it doubles the risk of them getting admitted to a nursing home.
Okay, that's
Now
interesting.
that being said, which is why just now in the previous slide, the other treatment consideration is the overall clinical profile of the patient, right? If let's say they've got like really severely impaired swallowing, right? They have problems with like swallowing pills.
Yep.
Then one thing is to consider, then is it really worthwhile? I mean, adding on to the pill burden. So these are the other considerations to take note of.
Understand.
Yeah. So even though cholinesterase inhibitors have been traditionally approved for mild to moderate dementia, because of the trial that I mentioned, right? Some people even continue all the way into the severe stages.
Okay. Okay.
Yeah. But if let's say really that there is no perceived benefit already, right? The person is already bedbound in nursing home, then I don't think there's any point in continuing, and then that's where you can consider stopping.
Okay. Then maybe another question to the other end of the spectrum. In patients with mild cognitive impairment, is there a role to start cholinesterase inhibitors? Because you did allude to the earlier the better. So is there any evidence in that space?
That's also a very good question. This is still also a mixed bag. The evidence is mixed. So some say it helps, whereas some other studies did not find any benefit.
Okay, so not very conclusive as of yet, lah.
Yes.
Okay. Okay, interesting.
Yeah. My guess is because the MCI, the road to MCI, sometimes is, if you can recall from the slide earlier about the different subtypes, right? Amnestic non-amnestic that kind of. There are certain subtypes of MCI that are likely not to be of the kind of pathologies that will respond to the cholinesterase inhibitors in the first place.
Okay. So maybe we
Yeah,
need
so
to
that's
select the patients a bit more carefully, and
correct,
then we
correct.
might
Yeah,
see
so
benefit in those.
that's
Okay.
my guess at this point in time.
Okay, interesting.
Yeah.
All right.
You will see sometimes people actually prescribe donepezil all the way like 23 milligrams.
Okay.
So I think just to take a step back, donepezil usually is given, you start at the lowest dose and see whether they have any side effects.
Okay.
And for like donepezil, you start at 5 milligrams at night. And then after about 4 weeks or so onwards, you can actually increase it to 10 if they're tolerating it well.
Oh.
Now, because of a trial that they did for 23 milligrams that found the benefits, right, for severe dementia, we have started seeing some of the patients being put on it. But our experience so far is that most of them are unable to tolerate it because of the GI side effects.
Okay.
Yeah. For Exelon, which is a rivastigmine, right? Because the higher the dose is also better. Yeah, so for like even a mild to mod AD, they even found that like a 13.3 milligram formulation is better than 9.5.
Okay.
For cognition and ADLs.
All right. Okay.
Okay, so these medications are overall, right, not recommended for those with vascular or like frontotemporal dementia, but you do see that people try sometimes for vascular.
Okay.
Whereas for FTD, then you see that the cognition will worsen.
Okay.
The other class actually only consists of one drug, which is memantine.
Yeah.
And this is trying to reduce the neurotoxicity.
Okay.
Okay, based on the glutamate that's being released from all the degenerating neurons. And they found that memantine is particularly useful for those with moderate to severe dementia.
Okay.
Yeah, and can be used both as monotherapy or dual therapy.
Okay.
Yeah, and so they found that there is a small benefit to cognition, ADLs, and global assessment. But more importantly, there is also an improvement in the mean behavioral symptoms.
Okay.
Yeah, one thing to note is that for those with impaired crack clearance, yeah, then you need to dose adjust.
Okay.
Generally quite well tolerated. Common ones would be like dizziness, headache, constipation for the side effects.
So given that the side effect profile seems a bit worse for the acetylcholinesterase inhibitors, right? If they can't tolerate, right? And let's say they are only like mild to moderate dementia, there's still no role for memantine in those instances, right?
Yeah,
Okay.
I think you can try, but so far I haven't seen anyone who has responded well to it in terms of they don't really report any improvements in terms of like the memory, for example.
Okay. So it's more in terms of like the behavioral aspects, and that's what you tend to see more in the more severe cases.
Yeah.
Okay, got it.
So I think based on your questions about dosing and all that, I think this table is able to summarize it all quite well.
Yep.
Where donepezil, like I mentioned, you start at 5, can increase to 10 after about a month or so. Whereas rivastigmine, you also start at 5, and then you can increase to 10 after 4 weeks. Rivastigmine capsule, I think it's 2 weekly increments.
Okay.
And then one thing to note is actually donepezil actually has an oral dispersible formulation, which is then quite helpful.
All right.
They don't really need to swallow, just disperse in the mouth.
Okay, thank you.
Yeah. Memantine itself, usually we start at 5, and then really depends, but you can increase it as fast as a weekly increment up to 20 milligrams a day. So from 5 to 10 milligrams OM to then 10.5 and finally 10 BD.
Okay, got it. Can. Okay. So yeah, so I think we've covered quite a lot today. Thanks a lot, Dr. Matthew. Maybe we can just go back to this patient, and maybe before we wrap up with the take-home points, one last question I kind of had, and maybe we can sort of like link it to this case, is which patients will actually really benefit from like a geri referral, a geri follow-up, and if let's say and what can be done, let's say if it's more of a watch and wait kind of approach that we are taking, if let's say we happen to be following up patients for other issues but concomitantly have perhaps some cognitive issues, practically how do we navigate this space lah? So I guess for Madam Tan, let's say her UTI resolve, she gets better, and maybe along the way with further history, we did get a sense of possibility for maybe features of let's say AD, but at the same time there is possibly an overlying element of delirium. How would you advise in terms of following up, and yeah, as in terms of like, let's say a geriatrics referral?
So for this case, right, I think what is the most important thing is to really tease out, this functional decline over the past year. Yeah. So as we discussed, very early on in this talk, is really getting a proper history, proper assessment. Now, with regards to your question about then what warrants a geri referral, to be honest, I think if there's something that you're uncomfortable with handling, right? Yeah, I think then that is already one reason to get us on board. Now, the other thing is, of course, for even the diagnosis of dementia per se, yeah, usually you need either a neurologist, psychiatrist, or a geriatrician to make that formal diagnosis. Okay. So which is why when you see you're filling up AICs, then when you're filling up that someone has dementia, they'll ask you, right, whether the patient is being followed up by someone. The original diagnosis has to be by one of these suspects.
Okay, I see. So I mean, in the sense that even if it's clear cut, like as a generalist, and I mean, if let's say we go back to some of the diagnostic criteria, and quite certainly the patient, I mean, I guess in the more gray cases, definitely, but in instances where it is quite definite, generally speaking, the first diagnosis should still be ideally made by a specialist lah.
Yeah.
Okay.
Yeah, so I think in terms of the take-home points, we've covered quite a lot today. We've really talked about, the spectrum of cognitive impairment from normal cognition all the way through SCI, MCI to dementia. And then when and how to assess these problems, being aware of the symptoms and features of the different subtypes, the assessment and diagnosis, what kind of investigations to do, how you stage the dementia, and the management. Right. And one thing that I want to share with you, right, is this mnemonic that was taught to me, by one of the geriatricians that I find that is something that is so helpful that I still bring with me as I see patients. Yeah, and first and foremost, you think about the assessment, right? Am I making a right diagnosis here? And once I have made a diagnosis already, how do I go about with the education of the patient and caregiver, breaking the bad news, counseling, and what are the medications to consider here?
Okay.
Sometimes, especially in the moderate stages of dementia, you may get PTSD, like I mentioned, and this will have to be then managed both non-pharm and pharm. Okay. And I think in recent years, there is emerging evidence that pharmacological treatment for BPSD entails more risk than they should. Okay. And it really outweighs the benefits. Okay. So I think really non-pharm, using an approach like the DICE approach, DICE, is quite a good way of managing these issues. Have you heard of the DICE approach before?
No, I haven't.
Yeah, so DICE, right, is D for describe.
Okay.
I for investigate. C for creation. And then E for evaluate.
Okay.
So essentially, you're trying to understand, what is triggering all these behaviors, right? What's the antecedent to the behavior, and what are the consequences, lah? And see whether you can then put in an intervention in place to avoid the triggers in the first place.
Okay.
So case in point, right, is that there was a patient, who was always very agitated, wanting to go home when he was at the daycare center.
Okay.
Okay. Yeah. So when the caregiver comes to with all this stress, cause the daycare center cannot manage, right? If you dig through more, then and you will come to realize that actually the reason for triggering the behavior is because the patient is sitting near the exit. The exit is in full view. Okay. And he sees pairs of shoes on the floor. So by seeing door and shoe, he kind of linked it to, hey, I need to get out of this place. So by speaking to the daycare center, okay, and rearranging his seating arrangement, he faces away from the door and out of sight of the shoes. He no longer had that behavior.
Okay.
Yeah. So it's really understanding, going down to what is really the core issue here that's triggering these things. Because they wouldn't be able to tell you. It can sometimes be, almost like second nature to them.
Yep.
Yeah. So this is where understanding, the triggers for the behavior, or even like sometimes unmet needs, biological needs, constipation, ARU, all these can also trigger off behaviors.
Okay.
Yeah. And of course, with behaviors, it can be very stressful at times. So it's important to check in on the caregiver, who is sometimes described as the silent patient, and see what kind of supportive community services you can put in place to help them.
Okay.
Then D is really assessing the care needs, what the risks are, for this particular patient, and how you can work around that.
Okay.
Yeah, so sometimes it can be like switching a gas stove, to an induction cooker, that kind of thing. Yeah. So it's taking creative means to achieve the same goal, right? Of making sure that the patient is safe at home. As the dementia progresses, like I said, it's important to start the ACP discussion early, right? And be able to discuss, all these issues in advance. And of course, as they become more debilitated, we also ask about how we can help them in terms of like financial subsidies and schemes. All right. So I think this A to F approach is really quite helpful and helps to really bring all these into something more digestible, in terms of the management. And I think this is quite holistic.
Thanks a lot, Dr. Matthew. Yeah, I think it's what I found really helpful is the various frameworks that you have provided, because I think all the way from the start of the evaluation to the management is that there are so many things to consider and bear in mind. Apart from the medical aspect that we are very used to considering in various management of various conditions, I think what's very important is actually beyond the medical, the psychological, the social, as well as the emotional aspects of patients, that sometimes is easy to neglect. And I think having these frameworks is really helpful in allowing us to, I guess just sometimes just think systematically, even if we can't come to all the answers or necessarily formulate the full management plan, but at least to know which are the different parts and domains of things that we need to consider. So I've really found it very helpful for myself in terms of what I've learned from today's session.
Okay, great. Great to be out. Thanks for having me.
Okay, thank you very much.